Hi, I'm Dr. Ken Sharlin. I have spoken with you previously about lumbar punctures and what they are and why we do them. So today I thought I would continue the series on diagnostic testing in neurology, and this applies both to conventional neurology as well as functional and regenerative medicine, because we always have to start with clearly identifying what is the problem that we're treating. So I'm going to talk with you today about nerve conduction testing and electromyography. Let's start out with defining this just a little bit, because in the common language of neurology, if we're just talking with each other, I might say to my nurse, hey, this patient needs an EMG. Now, EMG stands for electromyography, and technically that is just one part of this test. But we tend to say EMG for short, referring to everything. So if you hear that, it can be a little bit confusing. But I will explain what electromyography is specifically in a moment. I do want to start off with nerve conduction testing, which is very often part of this test and in fact goes before the electromyography part. And I want to talk a little bit about why we do this test to begin with. What neurologists actually focus on is what we broadly call the nervous system. And the nervous system can be divided up into the central nervous system, which is the brain stem, and the spinal cord, and then the peripheral nervous system, which is everything outside the spinal cord. So those are the roots that are coming off of your spinal cord. They then form a web of nerves in the pelvis, as well as in this sort of neck, shoulder area called a plexus. They then eventually sort of fuse and divide, and they form the individual nerves that run down into the arms and legs. And of course, you have nerves around your trunk as well. Some of these nerves are going to be controlling muscle, so we call them motor nerves. That's any nerve that activates a muscle. We also have sensory nerves, and those sensory nerves are sending information to the central nervous system, to the spinal cord, to the brain. Not always to the brain, sometimes just up to the spinal cord and back, but they're sending information to the central nervous system. And for that reason, we also sometimes call them afferent nerves to the central nervous system. In contrast, motor nerves can sometimes be called efferent nerves. Now, those motor nerves eventually activate the muscles, and they don't actually touch the muscle. There is an area where they come very close to the muscle. It's called a neuromuscular junction. And then the nerve ending secretes out a chemical signal called a neurotransmitter. Generally, this is something called acetylcholine. And that acetylcholine chemical is picked up by a receptor on the muscle. And then finally, that leads to a chain of chemical reactions that causes the muscle to contract. So the neuromuscular junction is sometimes affected in diseases such as myasthenia gravis, which is an autoimmune disease in which the body's own immune system attacks the receptors for the acetylcholine. So we call them acetylcholine receptors, and it leads to weakness. That's a little bit of a digression, but the point is that nerve conduction and EMG testing can be used to evaluate everything outside of the central nervous system, right? So what we call the peripheral nervous system. And it's also important to understand that if you, for example, have weakness or numbness or imbalance, just because you have those symptoms, unless those symptoms are caused by a peripheral nervous system problem, a nerve conduction test, an EMG test, is not going to tell you anything about why you have weakness. So we have to have it either related to nerve roots, the plexus, the peripheral nerve, the neuromuscular junction, or muscle itself. And that's where nerve conduction studies or EMGs come in. So having said that, I've given you these different parts of the peripheral nervous system. We then design a test around what we think is going on. Now, there are some times where a doctor might refer a patient to me and it just says weakness. That's not the most ideal way to approach nerve conduction testing with the patient, because it's kind of like an X-ray machine. Let's say you have a broken leg. If you are sent to the radiology department and they have no idea why you're there, they just have X-ray machines, and they do a chest x-ray, but you have a broken leg, it's not going to tell your doctor anything about your broken leg, right? So how a test is ordered, how that test is applied, is just as important when it comes to nerve conduction and EMG testing. The more specific information we have, the better the quality of the test or the test result, the better information you're going to get back. So we could test for muscle disease, which is also called myopathy. We could test for neuromuscular junction disease, which is, well, called neuromuscular junction disease. And then we could test for peripheral nerve disease, and there are different types. So there's single nerve diseases, what we call mononeuropathy. So a couple classic examples of mononeuropathy would be, for example, carpal tunnel syndrome, which is a phenomenon in which the median nerve, so one nerve, median nerve, that's coming in and out through the wrist, a little tissue tunnel called the carpal tunnel. The motor nerves are going into the hand, so you can, for example, flex your thumb or abduct your thumb, technically. And then the sensory nerves are coming from your hand, going through that carpal tunnel, up your arm, eventually to your spinal cord and brain. But that's one nerve disease. Another classic one nerve disease is ulnar neuropathy, ULNAR, and that's very often an entrapment neuropathy around the elbow. Not always, but very commonly, that's where the problem is. Now, in contrast, you could have nerve disease in which multiple nerves are involved, but they're kind of random. So it's like one here, one here, one down here, one down here. We call that multiple mononeuropathies or mononeuropathy multiplex. I don't really see that very often. Usually these are in immune compromised patients, and fortunately things like AIDS as a disease or HIV as a disease is pretty well controlled by and large these days. So at least in my clinic, I don't see some of these more advanced complications of immune deficiency. This could be seen in certain cancers where the immune system is affected or other immune deficiency syndromes. But again, these tend to be somewhat rare. A much more common nerve disease that we do see besides the mononeuropathies like carpal tunnel syndrome and ulnar neuropathy is polyneuropathy. So polyneuropathy means many nerves, but it has a different meaning compared to the multiplex neuropathy. And that is a condition in which the nerves are affected very symmetrically, and the longest nerves are affected first. So typically, polyneuropathy starts in the toes and the feet, and then it works its way up the legs in a symmetric fashion. In fact, sometimes we call this a stocking distribution. And then eventually it may start to affect the hands, beginning in the fingers. And again, symmetric, so we may call this a glove-like distribution, or you may hear a neurologist say a stocking glove distribution. The most common reason someone has a polyneuropathy is diabetes. And unfortunately, it's a very, very common problem. Not only that, but below the surface, and what I mean by that is people come in and I say, well, are you diabetic? They say, no. When my blood sugar gets tested, it's normal. But your blood sugar is really only going to be as normal as your blood insulin level is for the most part, because insulin is a hormone that's secreted by your pancreas that pushes the sugar into the cell, and it helps to normalize your blood sugar. There can be disturbances in metabolism, in insulin levels, in blood sugar control. And it's kind of like when the sky gets gray and then it's going to really rain or storm. So before you get full-blown diabetes, you kind of have pre-diabetes. And in my clinic, I see a lot of folks who have not been diagnosed with diabetes yet, but they come in with neuropathy or polyneuropathy, and we end up kind of working backwards. I check their blood sugar, I check their insulin level, I check what's called their hemoglobin A1C, which gives me an idea of what their average blood sugar is over about a 3-month period. And very often they're either diabetic and they didn't know it, or they're pre-diabetic and working their way, unfortunately, toward diabetes. Remember, the silver lining here is this is a functional medicine clinic, so we can help reverse diabetes. It's a 100% reversible disease, not just because you're taking pills. Now, you could have a pinched nerve in your back or in your neck. We call that radiculopathy. You can also use nerve conduction EMG to test for that type of problem. And I did mention the plexus, which is that web-like structure of nerves that's in the neck shoulder area and also down in the pelvis. So we call it the cervical plexus or the brachial plexus. And then we have the lumbosacral plexus. And those can be affected for a variety of reasons, sometimes due to autoimmunity and sometimes due to trauma. I would say those are the most common. Occasionally can have tumors and things like that that affect those areas. Probably those are the most common reasons we would see the plexus involved. Okay, so now you understand why we're going to use this test, and that is to confirm the suspicion that a particular problem is going on, and then to be able to characterize it, and that's exclusively affecting the peripheral nervous system. So we're going to start with nerve conduction testing, and behind me is a machine that we call a nerve conduction testing machine. When I started my training, these were all old analog cathode ray type tubes, but now everything is digital and operates under Microsoft Windows. Sorry, Apple folks, and I love Apple, but we don't have any Mac G machines yet. Maybe one day, hopefully. I love Apple. But anyway, it's not an endorsement. Okay, so how does this work? Well, first of all, I'm going to just take a wire and explain if you're watching this on video, you're going to see kind of a green wire. And this is actually a ground wire used in nerve conduction testing, but I'm using it to make a point. If I were to take a pair of wire cutters and just cut this, and you can think of a, electrical cord at home, be the same thing. What would you see inside? You would see at the center the metal, that is the wire itself, and then around the wire is rubber. Now here, this rubber or plastic is an insulator. But on actual nerves, if we were to look at them on cross-section, what we see in the center is the nerve itself, and that's called an axon. And then that axon is wrapped in a fatty-like material that's called myelin. And in the peripheral nervous system, that myelin is produced by a specialized cell called a Schwann cell. Now, in the peripheral nervous system, nerves that are heavily wrapped in myelin conduct their electrical signal faster. Think of like the Michelin Man with all those, sort of ripples. The myelin is wrapped around the axon, and every place where there's just a little opening, just imagine it circling around and around the nerve, everywhere where there's just a tiny little opening, that's called a node or a node of Ranvier. And what happens is that the electrical signal is actually able to jump from node to node to node, and this enhances the electrical conduction along the nerve. So it is a fast signal conducting nerve. So the more myelinated a nerve fiber is, the thicker it is, if you will, the faster conducting it is going to be. And that's very important. It turns out that the nerves that are fast conducting are things like motor nerves and specialized sensory nerves whose job it is to detect the length and tension on a muscle. And that sounds kind of esoteric, but think of a spring and you're pulling back on a spring and how tight or how far back you're pulling. It turns out that this is absolutely critical for this incredible thing that we do as human beings, which is stand on 2 feet and not just fall over. So the brain and the spinal cord need to constantly detect where our bodies are in space. And that happens because we have these specialized, fast conducting, large diameter nerves that are sending a signal to the spinal cord in the brain. Those are the nerves that we can evaluate by nerve conduction testing. Now, this is important too, because in some cases, there are very small fiber nerves, sensory nerves, that are damaged. And they may even be damaged before the large fiber nerves are damaged. We call these small fibers. These small fibers are so small in diameter that the nerve conduction testing cannot actually detect any abnormality in those nerves if an abnormality exists. Now, what we call small fiber neuropathy is actually very common. Typically, it presents with, say, burning or tingling in the feet. And again, we see this in diabetics. And even though the nerve conduction test is not the right test to evaluate small fiber neuropathy, think of having, say, a magnifying glass and a microscope. If you have something really, really small, you're going to need the microscope. But if it's not too small, maybe you could see it with the magnifying glass. Nerve conduction testing is like the magnifying glass. But if you do have small fiber neuropathy and you come to someone like me, what I actually have to do is, first of all, exclude large fiber neuropathy with a nerve conduction test. And then I have to do what's called a skin punch biopsy. And it's a very almost painless, not quite, but almost painless procedure. The only uncomfortable part is a little bit of numbing. And then we take a little piece of skin with a specialized device called a punch biopsy instrument. And it's basically about the size of the tip of a ballpoint pen. So you can imagine most of us, if you've ever had a cut in your life, it's way, we've had a cut much worse than any skin punch biopsy you'd ever have. But that little piece of skin goes inside a test tube, and then it gets sent to a specialized pathology laboratory where, guess what? They look at it under the microscope. So nerve conduction testing for neuropathy, nerve conduction testing for muscle disease, nerve conduction testing for neuromuscular junction, for plexus, for nerve root coming off of the spine. I should actually say that the EMG, or what I'll call the needle portion exam, is critical for the muscle evaluation component. So that what I said was not quite accurate. But usually if I'm evaluating weakness, I'm going to start off with a nerve conduction test unless I'm just really focused and 100% certain that the problem is in the muscle. And then I'll just go right into the EMG portion. So what happens? Okay, we've done a lot of preliminary discussion. So now I'm reaching around, and what I have in my hand is a stimulating electrode. Nerve conduction testing uses electricity. Your nerves are like wires, and they do conduct an electrical signal. So in order to test that nerve, just like you test nerves in your house, we have to apply electrical signal to the nerve. So we also have what is called a receiving electrode. So the stimulating electrode and the receiving electrode, and these receiving electrodes are applied to different parts of the body, the arm, hand, leg, foot, etc., at specific points along the body, depending on which nerve I want to test. So if I'm testing for carpal tunnel syndrome, naturally that receiving electrode is around the hand, especially the thumb, and then just above the wrist, and then around the elbow as well. But I will be putting that electrode on depending on what nerve or what question I'm trying to answer, what nerve I'm trying to test. The stimulating electrode is then applied also to a specific area on the body. We actually have to use a tape measure to measure along the arm or leg, wherever we're going to be testing, so we know exactly the distance, exactly the point where the stimulating electrode is going on. And then I press a button, and then a little electrical signal is applied to the nerve. Now, a lot of people are afraid of nerve conduction testing. They are worried it's going to hurt. No one likes to get a shock. Is it painful? The answer is, it is a little uncomfortable. Initially, it is so mild you can barely feel it, and then it's kind of a tickle. At some points in the test, it can definitely be more uncomfortable. I have tested people of all ages, all genders. It doesn't matter, men, women. Very uncommonly have I ever had someone say they could not tolerate nerve conduction testing. I think it's mostly because we start out very light. The brain essentially accommodates to the discomfort. And by the time there are a couple of stronger stimulations, which really feel more like a kind of a thud or a strong tap, if you will. And it's so brief. I mean, it's a fraction of a second. The person's like, oh, and by the time they said, oh, it's over anyway. So it is a little uncomfortable, but no one needs sedation. We don't use numbing medicine. Very rarely have someone say that they're not able to tolerate the test. And it's going to give me valuable information about the nerve fiber itself, called the axon, about the health of the myelin surrounding the nerve, because again, that myelin is responsible for allowing for a fast conduction along the nerve. So guess what? If the conduction is slow on the nerve conduction testing, that means that the myelin is affected. On the other hand, go back to thinking about cutting one of these wires. And in fact, what do we see on cross section is typically we see a number of individual wire filaments or metal filaments, like a copper wire for a plug. It's not just one single wire. An old hi-fi stereo geek, and so I used to hook up my own, stereo equipment and speakers, and speaker wire isn't a single wire. It's actually a whole bunch of wires that are sort of wrapped together. So nerves typically have multiple axons. Say the median nerve I mentioned earlier is multiple axons or multiple nerve cells that make up the median nerve. And so we want to think of the population of nerves. And so the more they can pick up that electrical stimulation from the nerve conduction test, the larger what we call the action potential is. And if you want to know what an action potential is, think about two people holding a rope, and they're standing, 5 or 6 feet apart, and the rope isn't completely tight. There's a little slack there. And then what I do, let's say I'm holding the rope, and I have Aruna next to me. You can't see her, but she's holding the rope, and I flick my wrist, okay? And what's going to happen if one person's holding the rope, the other person's holding the rope, they flick their wrist, they're going to get a wave that travels all the way down from me to Aruna over here out of the frame. That is an action potential. So if I stimulate the nerve, it's going to send an electrical signal that is exactly like that, of a waveform, and how tall or high that wave is reflects the health of the nerve cells that make up that nerve, or the health of the axons. So the more axons you have, the taller the action potential. The fewer axons you have, the smaller the action potential, the smaller the wave. It turns out that depending on the type of neuropathy that a person has, we can determine if that neuropathy primarily affects the axon or primarily affects the myelin. So the height of the action potential, axon. The speed of the action potential, myelin. Simple as that. And it also turns out a lot of the autoimmune neuropathies tend to be more demyelinating, so we see changes in conduction. Also, the entrapment neuropathies like carpal tunnel syndrome or ulnar neuropathy will primarily, or at least initially, present with slowing. So think of a highway that goes from 4 lanes to 1 lane back to 4 lanes. Everything gets backed up. They'll get through, but they slow at that bottleneck. If that goes on for long enough, eventually the axon will be damaged. And say in the case of median neuropathy or carpal tunnel syndrome, the person ends up with atrophy of muscle in their hand. That's very serious. It's what I call the do not pass go, do not collect $200, if you remember the game Monopoly, because I always say you go directly to a surgeon if you're already getting loss of muscle mass in your hand. That's serious. A lot of times we can treat carpal tunnel syndrome with a nerve block injection, with hydrodissection, with occupational therapy, things like that. Those are separate discussions, but the point is, if you're having loss of muscle mass, you really need surgery. So we talked a little bit about nerve conduction testing and how we could determine which nerves are involved. What's the nature of the nerve involvement? Is it more the nerve cell itself or the axon? Is it more the myelin, or how fast the nerve is conducting? So we can really dial it in and get pretty specific about what's going on with the nerve, and from that try to determine what type of neuropathy it actually is. Some of them have specific names. Maybe you know someone who has a condition called Charcot-Marie-Tooth disease, and this is also sometimes called hereditary sensory motor neuropathy. This is an inherited form of neuropathy. It's actually not all that uncommon. And I have some patients with Charcot-Marie-Tooth disease, and you can detect that on nerve conduction testing. I'm going to wrap this up really soon, but I do want to talk about the electromyography component. I'm going to reach over and grab something here. And again, for those of you who perhaps are reading this in a blog, what I have in my hand is a sterile needle. Now, this needle is really an electrode. It's a receiving device. It connects to an amplifier, because muscles, just like nerves, have electrical activity, but in order to detect the electrical activity in the muscle, we have to put a needle in the muscle. So I'm not injecting anything. These are single-use disposable needles. And in most cases, patients are, again, they're a little worried. Is it going to hurt? I usually tell them, because I start off with nerve conduction testing, that actually, I would say nerve conduction testing is probably more uncomfortable. And a lot of times they say, I didn't even feel that needle go in. But this needle is going to be connected to a cable. There's no more stimulating electrode. There may be what we call a reference electrode, depending on the type of needle used. This is what's called a bipolar needle. So the reference is on the needle itself, not on the skin surface. That's personal preference, what kind a neurologist or electromyographer wants to use. We'll get the same type of information either way. So again, we're thinking about muscle disease here primarily, and usually it's either in my experience, it's usually an inflammatory muscle disease, such as polymyositis or dermatomyositis, for example, sometimes inclusion body myopathy, which is a degenerative, despite the fact that it's sometimes called inclusion body myositis, it's actually a degenerative disease of the muscle. We see muscular dystrophies as well. I've seen some myotonic dystrophies, which are also not terribly uncommon and kind of make for an interesting exam by the electromyographer, because the muscle has a sound, and the sound in myotonic dystrophy is sometimes called a dive bomber sound or dive bomber effect. So we're now in the portion of the exam where we're evaluating muscle, right? And different muscles are chosen. The needle is inserted into the muscle. We listen to the muscle at rest, meaning you're not moving, you're super relaxed in that muscle. And then I'm going to ask my patient to activate that muscle. And because what happens is when you start to make like when you make your biceps muscle strong, for example, or if somebody puts their hand on the top of your foot and then they say, go ahead and push up against my hand, and that's activating a muscle called the tibialis anterior. Muscles have fibers, and as you put increasing tension on the muscle, you're basically bringing into play more and more muscle fibers until you reach a maximal contraction. The muscle fibers have a relationship to individual nerve fibers, and then the neuromuscular junction or end plate that goes with it or between the nerve and muscle, those are called motor units. So what we actually see on the screen when you're contracting a muscle more and more and more is that you are recruiting, and that's the term we use, recruiting motor units. Now, I've said that we can use the needle exam to evaluate muscle or muscle disease. There is another very common scenario in which we use the needle examination, and that is when we want to know if the person has a pinched nerve in the neck or a pinched nerve in the low back. We call that radiculopathy because the nerve root is the radical, so radiculopathy. And the specific muscles that are chosen to evaluate for a pinched nerve in the neck or in the back are chosen because we know what nerve roots control those muscles. For example, your deltoid muscle up here is C4, 5, 6, triceps C7, 8. Down in the hand, a tiny little muscle called first dorsal interosseous is C8 and T1. That's the cervical nerve root, first thoracic nerve root. And so by evaluating these muscles, we can begin to localize which nerve root has been pinched. Say if you have a disc problem pressing on a nerve root. So I've tried to give you a quick overall picture of nerve conduction testing and EMG. It's probably a lot of information all at once, but I hope it was helpful to you. We do EMGs all the time here at Sharlin Health and Neurology. I've been in practice about 30 years, so I have done a lot of EMGs, and no politics here. I don't bring politics in, but I like to quote President George W. Bush because he had that expression where he's talked about kinder and gentler. So I always say I'm the doctor who does the kinder, gentler EMG, because people come and see me and they say, oh, I had one, it really hurt, and they stuck me here. I'm like, it's going to be okay. I do the kinder, gentler EMG, and they love it. And they're like, oh, Dr. Sharlin, it was not as bad as I thought it was going to be. And you were so much better with it than last time I had this test. So you can have a lot of confidence. We're not going to make you terribly uncomfortable. I'm going to chat and get to know you. And by the time we're done the test, we've gathered all the important information. You'll be completely relaxed. We'll We'll have some good information. We can have a follow-up visit, go over the results, and really get a better understanding of what's going on. Again, that's what we call our identify pillar in our unique 5-pillar system here at Sharlin Health and Neurology. And once we've very clearly identified the problem, we can then talk about a variety of solutions, including the investigation of those root causes and utilizing my team and myself to take that deep dive with you and give you that personalized approach to integrate all of those root causes into a plan that is uniquely for you and ultimately gets you the results that you really want. So thank you so much for listening. It's been a pleasure to visit with you today. We'll talk again soon.